Good evening, everyone, and welcome to today's webinar by Project Step 1. The topic for today is actually management of COVID-19, a UK experience. Let me give you a quick introduction of Project Step 1. Project Step 1 is a non-profit that was set up in March 2020 to fight against COVID-19. The intent is to keep people indoors and help them with their medical healthcare needs by connecting them with a doctor remotely. Today, Project Step 1's Telemed Helpline is one of India's largest telemedicine effort in partnership with 12 states and adding new states almost every week. As a collective effort, we have over 6,000 plus volunteer doctors and about 100 technologists, entrepreneurs, and operators coming together. They are able to serve people absolutely free of cost by answering over 30,000 calls every day. With that, let me introduce our panel for today. Professor B. Nirmal Kumar, consultant, otolaryngologist, Director of Medical Education, WWL NHS Foundation Trust. He's also the President of ENT UK, ENT Research Lead, NIHR GM Clinical Research Network. He's an honorary professor of Edge Hill University and Edge Hill University Medical School. The topic he will be covering today is the COVID-19 personal protective equipment, loss of sense of smell as a marker infection. The second speaker for today is Dr. Abdul Ashish, who is a consultant respiratory physician, DMD respiratory lead for COVID-19, WWL NHS Foundation Trust. Sorry, I think if others mute, that will be good. WWL NHS Foundation Trust, Greater Manchester, CRN. He's the lead respiratory research in Northwest, lead recruiter for COVID recovery trial. He's an honorary senior lecturer in Edge Hill University. He will be covering initial presentation and management of COVID-19 UK experience. The concluding remarks and the questions will be handled by the chairpersons, Dr. Bharati MB, who is MS ENT and DNB. She's the president-elect for the 2020 AOI, Professor Department of Otorhinolaryngology, JSS Academy of Higher Education and Research, Mysore. We also have with us Dr. Jairaj PS, who is MD General Medicine, DM for TB and Respiratory Medicine, Professor and HOD, Department of Respiratory Medicine from JSS Academy of Higher Education and Research, Mysore. Thank you very much for your time. I'll now hand over to Nirmal, Professor Nirmal.
Thank you. Thank you, Derek, for this very kind introduction and for the privilege of coming and speak to this group. I hope that this can in time reach a wider audience through your very commendable efforts with Step 1. My introduction is to tell us about the experiences that we've had managing this COVID pandemic and the lessons from the United Kingdom. I have to acknowledge some colleagues here who have contributed to my work in this arena, particularly Professor Claire Hopkins, who is the president of the British Rhinologic Society, it's a subspecialist society within ENT UK, and my own trainees, Rajesh and John. So this, I would like to commence with a memoriam to the first UK frontline doctor who died after contracting disease, COVID-19, in the line of his work. He was an ENT colleague of mine, working in pediatric ENT. This was much before we even knew that COVID was a problem. So he contracted this in early March, and by the time we knew of this illness, he was already seriously ill. And in spite of the best efforts at treatment with ventilators and extracorporeal membrane oxygenation, he sadly passed away. But his was the starting point in enabling us to face up to this challenge and get appropriate protection. And I was on the front line in many ways. I was a clinician working in the hospital, but as president of ENT UK, this was a time I did not choose to be president, but it was important to rise up to the challenge, because not only colleagues, but trainees on the front line were being exposed to the risks of contracting without appropriate protection. And I was able to work with a lot of colleagues to evolve in the face of this rapidly changing disease, learning from colleagues in Italy and in China, and passing on our various measures to protect to many countries around the world. I've received many thank you messages from many parts of the world, including the United States of America, where our guidelines and our suggestions for protection were followed. Of course, the knowledge about aerosol generation was something completely new. This was something that we probably did not know of. But one thing was clear: ENT and any exposure to the airway, not just the respiratory, but the upper airway, was one of those big risk factors in aerosol generation and exposure to that. We work closely with Public Health England, and a lot of the information that we provide is referenced and available freely on our ENT UK website, that I would recommend to colleagues and doctors and patients to look it up. It is freely available. I won't spend too much time on telling us what this novel coronavirus is, because we are all experts now. You have seen enough YouTube and other WhatsApp videos about this. But it soon became apparent that this was not restricted to China or Italy or Iran. It became a pan-European issue very rapidly. And while the UK and the British Isles are an island, we weren't immune, because the rate of transmission through people traveling was very high. The salient points here are the exposure to the virus in unprotected individuals, with high viral loads being detected in the nose and the throat. And those of us in the front line working in the upper airway or in close proximity had this exposure. We were able to convince Public Health England that aerosol generation was of great importance to understand. The interesting thing for a non-medical or a community practitioner to be aware is sneezing is one of the biggest aerosol generators that you can think of. So when we sneeze, it is the equivalent of doing a procedure in the nose and bringing out the viral particles in the aerosol. We quickly established a national registry of ENT surgeons affected by COVID in the UK and linked it to an international registry, because always information, learning from each other is partly about knowing what to do and not making the same mistakes. And I hope that that is one of the big things we were able to introduce, a national registry, where we then were able to support colleagues. We also sadly learned, and this is of may come as some surprise to the Indian subcontinent or in other parts of the world, that the black and ethnic minority healthcare workers had a higher risk of contracting and having the most serious effects of the illness. The cause of the higher fatality and the mortality is unclear, if I'm being honest. Dr. Ashish and myself have discussed and considered things like vitamin D deficiency. Of course, as you may or may not know, in the United Kingdom, our exposure to sun is very much less compared to in India. And in a darker colored skin, maybe the vitamin D defects or deficiencies may be a factor. Or is it genetic? And whether socioeconomic factors, because a recent report by the Department of Health showed that certain ethnic minorities have higher illness rates because of perhaps deprivation and socioeconomic factors. The big advantage we had was this knowledge gained from the previous SARS virus in Canada, the MERS virus in Hong Kong, and the exposure in intensive care facilities when you're intubating people. But there was also exposure in doing other procedures, doing a tracheostomy, doing an endoscopy of the upper airway. And therefore, the picture on the right, where we examine patients with hardly any protection, is no longer viable. We have to wear the appropriate protection, and I think India is very good in making it available, but it is essential that you have the appropriate FP3 mask. Is an ideal protection for intense aerosol generation procedures. And the one step below, which is also available, the N95 or FP2, is reasonably protective, except if there is very intense exposure. But the surrounding other materials, such as the visors, the long sleeve gowns, these are all important additions and not just an appropriately fit tested mask. We had a great deal of difficulty in initially persuading Public Health England, which is the equivalent of the Ministry of Health in India, to accept that the guidance for protection was in ENT UK suggested 4 weeks before Public Health England accepted. But finally, we made them understand the importance of aerosol generation protection. Plastic surgeons, dermatologists, eye specialists, their oral surgeons, dentists were all very grateful to the lead that ENT UK gave, and the success in getting that updated guidance that was approved by Public Health England was the real success. There was a media campaign. I have been on television umpteen times and in news cuttings before we could get them to accept. This is a quote from one of my colleagues. She said to me, she's our treasurer for ENT UK, our collective effort and the leadership that ENT UK showed may have helped save the lives of many clinicians and many colleagues, and of course patients alike. And I was very, very humbled to see that statement that she put out in a report. The second part of what I would like to talk about is about the loss of sense of smell. I acknowledged already Professor Hopkins. She and I published a statement early on in March, in the 21st of March, which went viral. It went around the world faster than the virus did, which was a good thing in some ways, because many countries, the media all over the world, in the Times of India, in the Hindu, Indian Express, in New York Times, the loss of sense of smell as a marker of COVID infection. And we were helped considerably by the number of celebrities who also supported us, and people like the footballer Gary Lineker and many others understood and also described. Prince Charles recently said that he hasn't regained his sense of smell when he acquired COVID. But again, this was something that we had a battle on our hands. In the Public Health England's protection battle, I took a lead. In this, I was supporting Professor Hopkins when she took the lead. But we were saying we knew of thousands of patients who were having sudden onset anosmia, but were not self-isolating. And if this happened in young, fit people and healthcare workers, this caused a spread in the community before even the introduction of masks, which we now all use. So that was something that was unclear. We now know what are the main issues when we lose the sense of smell, and now know it's an official symptom. But at that time, it was only one of those oddities. Of course, there are safety issues when you lose the sense of smell. Of course, there are pleasant senses when we eat and drink. And of course, the unpleasant side, I don't think I have changed too many nappies in my life, but it is an important aspect when we have the pleasures of the sense of smell versus the absence of it. The very interesting thing in this was, even before we announced this, Google Trends and similarly other search mechanisms, search engines were reporting that people were investigating their sense of smell loss suddenly during this outbreak. And by just following that, we can track the extent of the COVID infection that seems to be following with the illnesses and the death tolls. And again, we did many studies, and we are also reporting on many others where we tested these patients. For example, this test, this paper by Moin et al. Showed that when COVID patients were tested, nearly 100% of them had a loss of sense of smell or a diminished sense of smell. And while you may be anosmic in 50%, at least some reduction of the sense of smell. This was not associated much with disease severity, they said. But in our finding, and only in the last few days, we have completed a survey of healthcare workers in London, Manchester, in Wigan. We surveyed 1,000 healthcare workers. And just like step one, I wish to acknowledge a company run by an Indian entrepreneur called Jayesh Taylor in BVM Medical, who produces some equipment, but he immediately understood the impact on Black and ethnic minority and general healthcare workers and gave us funds to help in this survey. So this survey showed us that out of 1,000 patients who had healthcare workers who were surveyed, 600 reported in the last 2 to 3 months a loss of the sense of smell. These are fit and well people, many of whom did not have the severe symptoms. And 20% have no other symptoms. And that's the extent of the transmission. So you must remember that healthcare workers can sometimes be spreading this, or even key workers like delivery drivers, etc. So we pushed Public Health England to accept that the loss of sense of smell of sudden onset should be accepted as a COVID marker. Look at this statistic here. 60% of the prevalence of the olfactory dysfunction where the sense of smell is lost in the COVID positive population. And if you flip this around to see what is the percentage of the sudden onset loss of smell people testing positive, is about 60%. And again, this is something that may be borne in mind. There is a certain false negative rate when we test for the COVID test. We know that. So it's one of the strongest predictors of the COVID infection that we have. Of course, we know of the continuous unrelenting cough. We also know of the high fever. But the lack or sudden onset lack of the sense of smell is one of the really big ones. There are great details we can go into of the postulated hypothesis of how this coronavirus 2 is affecting the receptors in the nose. There is viral entry, binding to the ACE2 receptors, replication, and the downregulation of certain enzymes. And in that process, there is the first tendency to lose the sense of smell because the olfactory neurons in the roof of the nose are the most exposed in that sense. And of course, we know of all the other symptoms, and Dr. Sheesh will give you a whole description of the rest of the disease process and treatment. And the important pleasurable link that we have, the sense of smell is not isolated. We have the taste that is affected as a secondary thing. We call that agousia, loss of taste. But it's really overall function, the flavor, the gustatory function, they are all inextricably linked. And the sweet, salty, sour taste, etc., is a byproduct of the lack of the sense of smell. And certainly, the sense of smell adds flavor to what we do. A lot of patients recover their sense of smell fairly soon, and in these young people who have a loss of sense of smell, we find that their recovery rates are pretty quick. Those who do not, I again refer you to the patient information leaflets that are available on our ENT UK website, and smell retraining. And there's about 10 to 20% of patients in whom the sense of smell loss lasts for more than 6 to 8 weeks. And we have published more than 6 or 7 publications in the last few months explaining this loss of smell, how it recovers, and the recovery from it, and the things you can do to recover, which is available on our website and is available freely to patients to look at. So the differential when we have COVID-19 is the sudden onset loss without an associated head injury or trigger. And this is one of those take-home points that we talk about. It is one of the most predictive symptoms. It was finally adopted by World Health Organization, and then by Public Health England, which was such a pity. They were the last, almost, compared to some other countries, including the American, New Zealand, and many other European countries. And just recently, I was told that the Indian Health Ministry has accepted and added the loss of smell and taste as symptoms of COVID by the Health Ministry. This is from the Times of India just recently. So this will lead on nicely to Dr. Ashish going on to the respiratory aspects. But at the end of the day, the airway is one and the same. The nose, the allergic rhinitis, and the asthma share many common inflammatory processes, and the understanding of what triggers this, the links, the inflammation of the nasal lining, similar to the lower airway, is very important. And that link was well known. I ran a one airway clinic even before the COVID pandemic, where I see patients together with a chest specialist. We work together because many patients with allergies and allergic rhinitis should be evaluated for asthma, and the other way around too. A combined strategy to deal with these patients is essential. And on that note, and without wasting too much time, I will thank you for listening to me. I hope I've conveyed the importance of protection, which is important in the fight against COVID, because we need to keep ourselves safe so that we can provide safe care to our patients. And this includes the understanding of anosmia. Thank you for your attention.
Thank you very much, Professor Nirmal Kumar. And I mean, this is a very good insight for all of us. I think a lot of the doctors will benefit from your experience in the UK. This is an excellent presentation. Thank you very much once again.
You're welcome.
We are doing the Q&A after the entire presentation.
Yeah, that's fine. That's best to do it at the end so that Dr. Ashish can do his presentation and we can take questions at the end, if that's okay.
Brilliant. I will now hand over the next presentation, which is the initial presentation and management of COVID-19. Again, United Kingdom experience by Dr. Abdul Ashish. Over to you, Doctor. Doctor, you're muted. Dr. Abdul Ashish, you're muted. So please unmute yourself.
Okay. So I think you may, can you see my screen now?
Yes, yes, Ashish.
Yes. Thank you. Thank you. Thank you, Nirmal. First of all, I'd like to thank Shashi for giving this opportunity, and really Step One for doing such a fantastic work. I'm going to take you through some slides which shares our experience. Just a moment. For some reason, this is, yeah, our experience of managing COVID. And this is really, it's a growing problem. As we can see, the world is still very much in the midst of COVID, especially India. So we'd like to share our experience. We'd like to believe we have seen the worst. We've had over 2.5 lakh cases. We've had, unfortunately, quite a bit of fatalities. The evidence is still emerging. It is still very much, we are learning about the disease, how to manage this. But we've had some, a fair number of cases and quite a few serious cases. And I hope you're able to see or you're able to learn from what we have found useful. So in this talk, I know there's a wide variety of audience in this talk, including some of the colleagues who are triaging in the front end, some of the specialists who are there in the hospital, and perhaps some intensivists who are there on right at the end, who are managing these patients. So I'm while trying to keep everything together for everybody. So I'm going to talk a little bit about the science, whom to suspect, from what the evidence is available, high risk, the evidence, how do we triage these patients, if patients are well enough when they're present, how to make sure there is safety net, something about ventilation, our local experience, and emerging treatment modalities. So who are we? I think we are here so Wigan is a town, it's in Greater Manchester, as you can see. We are here between Liverpool and Manchester. Those in India, they very well know about the football, but we are a very big rugby league team. So what is Wigan known for? Well, you're very unlikely to know that this is the famous Wigan pie. Everybody in the UK, of course, knows it. We are also known for Uncle Joe's mint ball. Some of you might know Heinz beans, but really for the medically inclined, we are really most well known for the orthopedic, the prosthesis, the hip prosthesis, which was invented by John Charnley in Wrightington, which is one of our sites. So we are a 3-site hospital in Greater Manchester, and we've got about 500 beds, of which majority of them are medical. We are a teaching hospital very recently and privileged to be looking after these patients. So why are we talking about COVID? We are here in terms of UK has seen the peak, but in India it's very much growing. I can see some states like Maharashtra, Karnataka, Tamil Nadu, much more in the north. The number of cases are growing day by day. It is also quite relevant because in our experience in UK, we have seen a lot of deaths of South Asian people. These are unfortunately healthcare colleagues who are in the forefront, and for some reason, they seem to be at a high risk of severe disease. Especially in the media now, since it seems to be very timely that India has over 4 lakh cases, and fortunately, there's not as many deaths, but the numbers of cases are growing rapidly. So the theme of our COVID management has very much been learning quickly on our feet, gathering and looking for the evidence, changing protocols, making our own pathways, enrolling as many patients as possible into the national trial. And as you would probably know, UK has come out with the first standardized treatment for COVID, recognized treatment, dexamethasone, which shows a survival advantage of people who are on the severe end of the spectrum. It reduces death by about 20% in patients who need oxygen and up to a third if you're in intensive care. So these are the other colleagues that you may want to collaborate with: the emergency physician, the hematologist, the rheumatologist, dietitian, ICU, and the palliative care team. And we worked very closely with all our colleagues, and those who are going to be seeing a high number of cases, then you should link up with these colleagues there, because their input is going to be very, very useful. So our own experience, we've seen close to 550 patients, but we are thankfully at the lower end. The peak is over. As you can see, in the beginning of April, we saw a big spike in cases. One of the unique things in UK is a lot of elderly population. They live in care home. They're particularly at risk of severe end of the disease. Now, one thing is to be said, majority of cases will have only mild spectrum of the disease. A small proportion will come in the hospital, and even a smaller proportion will end up in the intensive care units, have a severe disease, and are at the risk of dying.
Ashish,
So,
hello.
hello.
Does your slides have these,
No.
red lines?
No. I think it just, once I started presenting,
okay.
from the host side.
You can go to the Tanoceans and then you can just delete the lines.
Can I do that?
Yeah. In
yeah.
the screen, share screen only.
Yeah. That's gone now, isn't it?
Yeah. Now it's gone.
Okay.
Yeah.
All right. Thanks for that. Thank you for that. Okay. So, so very briefly, if I could share the science, I'm not going to spend a lot of time because that's not the idea of this talk. Let me see if I can close this. Oh my God.
What do you need, Ashish?
Just close this mouse, the bar.
Okay.
Are you able to close that?
Right. Okay. Annotate.
Let me see if
I
can.
Yeah, I've done that. Is it gone?
No, it's not.
All right. Is it still there?
It is still very much there. Let me see if I can do no.
Right. Hang on. Yeah. Okay. It's gone.
It's gone.
Okay.
Yeah. Okay. So let me go back to the previous. So I'm not going to talk a lot about science, but what it does is the virus, it triggers your innate T cell response, and a lot of responses are seen at the molecular level, whether it's a natural killer cell, CD8 and CD4, but also your adaptive response kicks in, which in turn provides the antibodies. So you can see it's a disease that the virus attaches to the ACE2 receptors in the lung, and it cascades all these responses, half of which is towards viral clearance, the T cells and the natural killer cells, whereas the other half, the adaptive immunity, it tries to fight off this by creating a hyper-inflammatory state, which is half the problem in COVID. So in clinical manifestation, this will be, you can measure some of these cytokines or the hyperimmune response, but for the frontline clinician, really, it will manifest in high fever, high C-reactive protein, lymphopenia, persistent fever, and this is evidence of what is actually going on inside. So it's a two-phase. If you look at the disease itself, the first phase is the viral response. When you get infected by the virus, you may or may not have very many symptoms, which is called stage 1. You could have a dry cough, low-grade fever, myalgia, and this is the time when people may brush it off as, oh, just a cold, just a body ache, I got a bit of viral fever. So these are initial, so there's no real discriminatory features at this stage, but if they present to the hospital, you could see lymphopenia and temperature. Once the disease progresses, the patients will almost always complain of breathlessness. It is, you can have low oxygen saturations, the chest X-ray changes, transaminitis, the liver function tests are abnormal at that point, and inflammatory markers start rising. You can see a rise in CRP, you can see a rise in white cells, And once the disease progresses further, you can see severe disease manifestation by seeing ARDS, persistent high IL-6 levels, and so on and so forth. We'll come to the management side of things a little bit further. So these are the phases in which you can see the patient. Mostly we see the patients who present after 6 to 7 days of illness. Those are the ones that we need to really worry about because they're entering from phase 2 to phase 3 of the disease. Very briefly, I'll talk about coagulation dysregulation. There is a cascade of events that happens within the body, which makes an individual hypercoagulable. They're in prothrombotic state, and we are seeing a lot of VTE, people with pulmonary embolysis, people with hypercoagulable state, which again causes the problems in management of this condition. So it is evidenced by high D-dimer, high fibrinogen levels, increased incidence of deep vein thrombosis and pulmonary embolism. It is also to be noted that due to high antithrombin levels, the usual dose of anticoagulation that we give to these patients are ineffective. And I'll talk about factor 10A monitoring in a little bit. So coming back to the symptoms, so when a patient presents to you, almost always they will complain of fever, dry cough, fatigue. As the disease progresses, they could complain of shortness of breath. But really, there is no one symptom. There is also a lot of vague symptoms that they'll complain about: muscle pain, sore throat, headache, chills, lower GI symptoms such as diarrhea. So people who are triaging these phone calls need to be aware, especially in this current climate, and you have to ask yourself, could this be COVID? So in UK, when a patient presents to the front door, these are the 3 cardinal symptoms that we look for. New onset of breathlessness. So a lot of people already have cardiac problem, people with chronic lung disease, but this is a new onset of breathlessness, which is worse from their baseline. Fever, persisting high-grade fever. In India, I think you would probably 100 degrees Celsius. In UK, 37.8 degree Fahrenheit. New persisting cough, and this is a feature we have seen particularly in young individuals, new persisting cough. So these are the 3 cardinal symptoms. When they present to A&E, there is a high suspicion of COVID. And so these patients are sent to a COVID assessment area in the hospital, which we have separated from non-COVID presentations. So who are these patients who are at high risk? And I'm going to talk through some of the evidence based on this and what is our local experience. So this is it affects patients of all ages. In children, there's not been so many case reports, so much of COVID cases have not been reported, but predominantly it affects adults, and that too in a severe manifestation for elderly. This is a death that you can see, death rate. In the 50% of death rate in UK is over 80 years of age. The rest 30% is about 70 to 79, and and waning down. One of the reasons for this is the waning innate response. The T cell response as you get older is a little bit more sluggish. It's not as robust, and because of that, there is high fatalities. So this is BMI. So BMI seems to have an adverse prognostic factor in patients who are having COVID. Half the reason is the level of ACE2 expression seems to be associated with adipose tissue. And therefore, the more of adipose tissue you have, seemingly you have a much more severe inflammatory response. So you can see the BMI in this chart. As your BMI grows, you have higher severe illness. These are people who are admitted to intensive care unit in the UK. So you can see the majority of them had a higher than normal BMI. So BMI, not just the obesity, not just, you have not just a hyperimmune response, there's a lot of respiratory dysfunction if you're obese. your respiratory mechanisms are slowed, airway resistance is increased, the gas exchange is poorer, and also you're much more likely to have diabetes, kidney disease, or cardiovascular disease, which is again poor prognostic feature. You are in a state of metabolic syndrome if you're obese. There's higher tissue level inflammation, and therefore, which furthermore adds to the severe response that is seen. So this paper shows the obesity in patients younger than 60 have a very severe COVID outcome. And it is the odds ratio are at least 2 to 3 times those than those who have got a normal BMI. So when you're triaging, this is something you might want to find out if weight has been an issue. And if so, just have it in mind that they're likely to have more severe disease. So this, unfortunately, is a disease which has preponderance for male sex. And we don't know the reasons for sure, but they're at least twice as likely to end up with more severe disease. Ethnicity also plays a big part in this disease. In UK itself, this is the representative population in the blue histogram, and the number of proportion of patients who actually have had severe illness. Actually, it's the other way around. So it's the orange is the local population matched on census, and the blue is the number of patients who are critically ill. So you can see the white population is 78% of the population, yet only 67 had severe illness, whereas in Asian population, it is 11%, it is 11% of the population, but 15% of them had severe illness. It's actually particularly worse in the Black population, as we can see. The people from Afro-Caribbean descent were 3.5 times likely to be admitted to intensive care unit, whereas Indians and or South Asian were at least 3 times likely. So there is something to be said about South Asian population, which seem to have more severe spectrum of the disease here, at least in UK. Again, this is a disease which affects people from poorer background more. So if you see the general population, people who are from the lower socioeconomic status, they seem to have more severe end of the spectrum. It may be due to the fact that they're bigger families living together, the social segregation measures are not taken as seriously, and hence they tend to have a higher death rate. So this is our local data from our own hospital, and you can see people with lung disease, cardiac problems, chronic kidney disease, and diabetes are much higher risk of dying. So if you put together, roughly 30% of the deaths were people from chronic lung disease, 30-odd% with cardiac problems, which is much higher than general population. So while somebody is triaging, you have to ask for history of chronic lung disease, chronic heart disease, chronic kidney disease, and diabetes, because these people have a much higher rate of severe disease. So if you look at it scientifically, people with cardiovascular and hypertension disease had a much more strong predilection for severe disease and ITU admission to a factor about four times. And those with lung disease were at least 3.5 times more likely than general population. This is a systemic review and meta-analysis which looked at over 2,500 patients and came up with these conclusions. So while we are reviewing or admitting these people, if they present to the front end of the hospital, it has to be kept in mind that these are the higher risk individuals. So this graph shows the level of intervention people are requiring. So roughly 25% of people who get severely ill require invasive ventilation here. And those, about 28, and those, if they are severely ill, very likely to require cardiac sort of inotropes. and some renal support as well. So you have to really worry when the patient is elderly, is a male, is a diabetic, hypertensive, other cardiac problems, and is obese. So these are the risk factors that you have to be aware of. Now, triaging, how did we triage in our own hospital? We kept the COVID areas and the non-COVID areas very separate, whether it is A&E, whether it is wards, or whether it's escalation areas where we are providing CPAP or ventilation. So we have kept them completely separate. Where you suspect patients in A&E, where patients suspected COVID are coming, people were in full PPE, that is an FFP3 mask, shields, and hazmat suits to protect the healthcare staff. Even on the wards, so we had a rotational, we had the rota drawn in such a way that each nurse who's in a bay is not staying there for more than 2 hours, especially if they are using high aerosol generating procedures such as CPAP. So it is a logistical nightmare to have these patients present to the hospital. Any patient who's going from A&E to the wards had a preset route, and the route was disinfected after every patient that ended up onto the ward. We were limiting physical examinations to very, very little, very minimum on absolute need, because you can make all the inferences from the blood test, from the x-rays, from the observations that is done. So I would urge clinicians to keep the physical contact to the minimum. So this is the suit, what it looks like, and it's really exhausting to be in this suit. This is myself with our colleagues in the peak of things, and you cannot stay here in this suit for more than an hour or two. So we used to review the cases. Fortunately, we've paperless system, so we can review everything in the computer in an outside cubicle, and the patient contact was kept very, very minimal. So this is, I'm not sure whether it's projecting very well, but the idea of this slide is we gave the clinicians who are not non-respiratory some aid memoirs to say what you need to look for. What is a frailty score when they present. I'll talk about that a little bit later. So this was given to front-end clinicians, casualty doctors, people who are triaging, some sort of aid memoir chart to say things that they have to look for. So once they present to the A&E, we need the clinicians, the doctors, the nurses to know what are the poor prognostic factors, who are the patients that you need to really concentrate on. And these are some of the features that we have found is helpful to identify those. Those with a low oxygen level, stats of less than 94%, those with low lymphocyte count, those who have given a history of pyrexia for the last few days, those with high CRP and D-dimer. We were checking regularly high ferritin, the ferritin levels as well, because it's a very accurate marker of the disease process, what is happening internally. We felt as we got better at managing this, we knew that vitamin D was a determinant who have severe disease. So we were checking it right at the time when they were presenting and correcting it as soon as we started treatment. Other measures which we found helpful is a lactate level and fibrinogen at the time of presentation. All of this is indicative of the cytokine storm that is happening within the system. So these are the rough indicators. These are the indicators which tells you the disease process is very, very active internally. So this would be the presenting X-ray of somebody typically affected with COVID. You can see the peripheral changes, peripheral soft inhomogeneous changes in the peripheral lung fields. So this could be a patient who could have low oxygen saturations on presentation, and very typically in the early phase of the disease will have this sort of appearance. As the disease progresses, you can see the infiltrates becoming more confluent, bilateral, and this was a patient who was ventilated within the first few days of presentation. This is a very typical appearance of those who end up with ARDS. The CT initially will show peripheral ground glass changes, posterior-basally, with normal areas of lung. We would do a CTPA at the time of presentation for anybody who's hypoxic, given that it will give you a distribution of the problem within the lung fields, but also tell you whether they have consequent problems such as a PE. Small segmental and subsegmental PEs, we're not able to see on the CTPA, but at least to the segmental level we can see, which helps us managing these individuals. As the disease progresses, you can see more dense consolidation in the peripheral lung fields, which we have found to be a very classic COVID presentation. So this is a very interesting paper by Gattitoni, which describes two different types of individuals who come, the type L and the type H. I won't go into the details, but in the initial phase of the disease, the lung is compliant. If you give oxygen, the saturations will come up. But as the disease progresses, the VQ mismatch becomes a little bit more exaggerated, and these patients will have persisting dangerous hypoxemia. How to manage them is very different in these two individuals. So in summary, radiology, we do a CTPA. It is to see the distribution, whether it's ground glass, which tells you early inflammatory phase, or dense consolidation, which is slightly later phase. The disease is almost always seen bilaterally, confluent, multifocal areas of ground glass or infective changes, consolidative changes, with a high incidence of thrombotic problems such as PE in up to 70% of cases that we have noted. So CTPA is absolutely essential in the initial evaluation. This particular paper has shown that the incidence is up to 70%, which every clinician has to be mindful when they're reviewing these patients. As soon as a patient comes to our front end, we assess their functional ability by what we'll call clinical frailty score. It is 1 to 9. 1 is a very, very fit person, and 9 is somebody who's terminally ill, completely bedbound. Between 1 and 4, we offer all invasive. So between 1 and 4, without going into details, between 1 and 4, roughly, these are active people. These are fairly, healthy people, as we would say. They're not dependent on others for daily help. Their activities, they're fairly independent. And we consider these people to be able to withstand or to be escalated to intensive care if needed. 5, 6, 7, 8, and 9, these are people which we feel would not benefit from invasive ventilation. So because they're frail, they don't have the physical reserve, and we feel these people, we have good evidence to show that these people do very badly if they're put on a ventilator. So we risk score them. This is very simple. It can be done on the front end by a clinician or even a phone triage to say how best we should be treating them. So our A&E physicians who would be seeing patients would be giving us a CFS score when referring. Some of these patients, when they present to your hospital, especially in the early phase, are very well. Their oxygen levels are good. Their X ratio is very minimal changes. They look well. They had fever. And we were sending these back to say, you actually don't need admission because your oxygen levels are okay. Your blood tests are okay. But we were giving them a finger SATS probe to go home with. And we were asking them to check their oxygen level twice a day after 5 or 10 minutes of rest. And if it falls below 94%, to ring us. So we would triage them and decide to bring them back to the hospital. In the initial phases, we did not do this. And a few young individuals presented within 48, 72 hours, much, much more ill and had to be straight ventilated in A&E. So this is something I would urge colleagues to give some due consideration if the infrastructure is able to provide, because people do get very ill very quickly. So in summary, we triage the hospital in such a way that people in the front end knew the processes at the back end. We gave them some tools to triage people who are at the high risk, and some pathways to created where people, if they were going home, they were giving adequate safety net. We predetermined the transport route from A&E to the wards to intensive care and disinfected the way every time a patient went up. And we limited the time the healthcare colleagues were in with these patients. We would make early decisions based on CFS score, initial presentation, CT, blood, whether this is a high-risk individual, whether we'll be offering invasive ventilation or not. Anybody, and we also put ceiling on whether patients would benefit from non-invasive ventilation, which I'll come to pretty quickly. Those who are not on for full escalation, we tried to cohort them in a separate ward with high input from palliative care physicians, from other general medical physicians who could manage these individuals, and therefore cohorted the individuals where we were going to escalate the care, whether it was non-invasive ventilation or invasive. So it helped us manage the situation in a responsive manner. Next, so in our experience, we triaging well at the front door is vital. Identifying your high-risk patients at the front door is vital. What are the high-risk signs it needs to be aware of, the clinicians who are triaging need to be aware of? Based on blood test and CT, these things, the clinician should be aware what are the signs. And you are all a team, whether it's casualty doctors, respiratory physicians, ITU, general medical physicians, you're all a team and you need to be communicating with each other to manage these patients well. So this roughly is our escalation pathway. We do a clinical frailty score as soon as they come in. Anybody who requires oxygen comes straight to respiratory ward, especially if they have good functional ability. Those who are severely ill or we feel will not be a good candidates for escalation, we will send them to the right-hand side of the pathway, go to a general medical ward to be managed by general physicians and palliative care doctors. We would recruit them to clinical trials in the front end to be able to avail one of the available trial treatments. Anybody who requires oxygen, we would prone them. Trial of awake proning, which is the big blue box in the middle. So we will put them on their tummy. It helps oxygenation. It improves their saturation. We will try and aim for a SATS of 94 and above. We will do a CTPA as soon as they come to A&E, before they come to a ward, once we make a decision to admit them. Anybody whose respiratory rate is over 25 persistently for an hour or two with low oxygen levels, we would consider non-invasive ventilation. At the time when we consider non-invasive ventilation, that is CPAP, we will make a decision about escalation. What are the parameters at which we will escalate these patients to intensive care or for mechanical ventilation? We'll have twice daily ward rounds on respiratory wards, and the second ward round is with the intensive care physicians to decide whether ventilation would be appropriate. Among the number of medications we would give them, and I would come to the next chart, but as you can see, as soon as the patient lands to our ward, we make these decisions very early on. Standard treatment, so as soon as somebody comes to A&E, we'll do a CTPA, we'll request D-dimer, we'll consent them and put them into a clinical trial, and we'll prone them and move them to the ward. Once they reach the ward, this is what we call a CPAP care bundle, which we have devised. We would do a ward echo. If there's a right heart dysfunction, very likely they don't well on mechanical ventilation, and we'll have that conversation with the patient and the family, with the ITU colleagues. We will check daily bloods. We will aim for these patients to be euvolemic. So we won't pump in too much fluid. We're very strict input-output chart. We'll put a catheter and measure that. We'll give some broad spectrum antibiotic to cover the bacterial infections. If they're diabetic, very strict blood sugar monitoring. We will replenish the vitamin D, and we will also give high dose vitamin C, 6 grams a day, because there's some evidence to suggest that it is helpful. Those who require non-invasive ventilation, which is CPAP, we give them a 2-hour trial. I'll show you what the machines we're using on a low setting, 5 centimeters of PEEP for as long as they can tolerate. And we would continue that and to aim for a lower respiratory rate, lower work of breathing, while we monitor all the other parameters like bloods, oxygen levels, and so on and so forth. Those who go on CPAP, it's very, very important to address their nutrition. So anybody who goes on CPAP, at least the first 48 hours, we give continuous CPAP, and therefore we give PPM to make sure their nutritional requirements are well met. So this is a machine that we use, this standard machine that we use for our OSA patients. We use it in a CPAP mode. We've devised a circuit whereby we put a non-vented mask, number one. We put an O2 entrainment port, and number three is the bacterial filter, which will connect to the machine. We'll start with a pressure of 5 to 10 centimeter of water and work it up to 15. Anybody who crosses 10 centimeters of water, we would be speaking with the ITU colleagues to consider mechanical ventilation. So if they're getting better, we'll continue with the CPAP for as long as it requires. Ideally, we want to see a respiratory rate of less than 25 for a period of time, say 12 hours before we take them off CPAP. Nighttime, mostly we will support them with CPAP, and we give trial of without CPAP in the daytime. If they're not getting better, really, we review anticoagulation, we'll check factor Xa levels, increase the CPAP settings, speak to ITU clinicians, and consider moving them to intensive care unit for elective ventilation. So as you can see, it is quite onerous, quite exhaustive what we're trying to do for these patients. Without going into details, we were regularly checking anti-Xa levels because, as I said, antithrombin levels are very high. So your usual therapeutic dose of anticoagulation based on your weight really is subtherapeutic in up to 50% of patients. And therefore, if you check anti-Xa levels and manage the anticoagulation appropriately to anti-Xa levels, that would give you a good anticoagulation. We were using tocilizumab as a part of recovery trial in those who persist with cytokine storm. So after 24 hours of admission, if the D dimer is going up, CRP is going up, the ferritin is going up, persistent fever with bilateral dense infiltrates on the CT, we will consider tocilizumab up to 2 doses. Towards the tail end of it, we had access to IL-1 blocker and Anakinra as well, but we haven't, to be honest, we haven't used it that much. In the last few weeks, we got access to remdesivir, and we were using it for patients who were on oxygen who are COVID positive. There is some evidence to suggest that it reduces hospital stay and improves recovery. Very lately, in the last 3 weeks, we've also used convalescent plasma from people who have, from patients who have recovered from COVID to boost the adaptive immunity. And there is some evidence that it works, but the jury is out. So up to 25% of our patients we enrolled into clinical trial, which is, I think, quite a high proportion. And now we are offering dexamethasone 6 milligrams once a day as standard treatment for anybody who's COVID positive requiring oxygen. So I'll discuss some local data and national data of what our experience has been in the UK. So this is the ITU register, so the Intensive Care Society of UK, who publish this data every few weeks, and this is one of the most up-to-date ones. Of those who get ventilated, 42% of them die. 57 get discharged. This is the whole of UK data, not just our data. And on average, they are on ITU for about 11 days. Those who require advanced ventilatory support, 50% of them will die. And it varies on a lot of factors, as I've mentioned before. So roughly, this is towards telling patients, relatives, from our large experience, up to 50% of these patients will die. And those who have renal support, those who go into renal failure, require hemofiltration, unfortunately, 62% of them will die. So if you aren't going into renal failure, multi-organ, then your chances of recovery while on the ventilator are low. Those ventilated in UK, at least 50% of them had moderate ARDS based on PF ratio, as you can see. So yeah, this is very typical ARDS chest radiograph. And now I'll talk to you about our own CPAP data. We did CPAP, ward-based CPAP for about 42 patients. 73% of them were male, mean age of 63. They were on CPAP between 2 and 13 days. The oldest survivor was an 82-year-old gentleman who had CPAP for 13 days. So sometimes you just have to persevere for things to work. But overall, 50% of our, if you look at the whole cohort, 50% of our CPAP patients died, 35% discharged, and the rest of the 15%, some of them are still in ITU, some have gone for ECMO and still on ventilators. So if you exclude those, this is a paper that we have published, which looks at early CPAP versus late CPAP. And what we found is if you initiate CPAP early, that means before the oxygen requirements crank up, ideally less than 4 liters per minute or less, the outcomes are much better. That is simply because we are reducing the work of breathing early, and it reduces the shearing strain on the alveoli, which further causes cytokine cascade. So this is our paper, and we have submitted a further larger paper of over 300 patients, which again reiterates the same finding. So if you're starting non-invasive ventilation, it's better to start early. So if we exclude the ones who went to ITU, we've got a 50% survival rate on those who go on to CPAP, which is really, there's not a great deal of data about CPAP internationally, about what's the survival, what sort of patients should go on. In our experience, anybody who has a CFS score of 4 or less, if they require 4 liters or more of oxygen, should have CPAP, especially if the work of breathing is high. So some of the pointers, clinical pointers, these are 2 groups of patients. The first on the left-hand side are patients who are managed on non-invasive ventilation, and the right-hand side are patients who unfortunately required mechanical ventilation or invasive positive pressure ventilation. As you can see, on average, the lymphocyte count is lower in these individuals. They also have very high D-dimers, which is, again, just an indicator of the cytokine activity and coagulation cascade problems. And C-reactive protein on average, as you can see, they have high C-reactive protein, yet again, a simple indicator of the cytokine storm. So you can identify these individuals early on. If they have a falling lymphocyte count, rising D-dimer, and a rising CRP, they are the patients who are having cytokine storm and very likely to have more invasive treatment requirements. So these are the respiratory rates of patients who went on to have invasive ventilation. As you can see, on average, their respiratory rate is over 35 persistent, 12 to 15 hours prior to being intubated. So this is a good indication, clinical indicator, that these are the patients whom you should consider for invasive ventilation. So in our experience, we have to triage early, based on clinical indicators and the patient-related indicators. High-risk features such as raised CRP, falling lymphocyte, high D-dimer, and fever are very, very simple measures that you can use to identify these patients. If you're providing CPAP, provide early, because you can avoid ventilation in some individuals. You have to have a close eye on these individuals. So at least twice a day, these patients have to be reviewed. CPAP has to be given early, and those who have poor prognostic features, as in the clinical indicators, they have to be escalated early. So those who get better, if you're sending them home, you will need to know that the recovery will take weeks. And those who have previous cardiovascular, respiratory, chronic diseases, they will probably take much longer. We have been sending patients home on home oxygen simply because they're static on oxygen for days together. So we send them home. If their oxygen requirements drop to about 2 liters, we send them home with a concentrator and we send a nurse, we get a nurse to contact them every day, and twice a week we have a nurse visiting them at home. Our readmission rate is less than 2%. So overall, these patients do get better slowly. So if you have community teams, as in my MBBS days, the community medicine teams, I don't know if there's an infrastructure for these patients to be seen at home, but if there is, that will provide a good safety net for these individuals and provide deterioration in the community, prevent deterioration in the community. From those who have recovered, post-viral fatigue and functional debility lasts for weeks. I'm talking 6 to 8 weeks or longer. And there's a big psychological impact. They become depressed, they're not able to do. So that sort of support is also very important for these patients to make a good recovery overall. I'm not going to go into detail of this, but this is the pathway we have created to decide who needs intervention from the community teams. Those on the right-hand side come straight back to the hospitals. Those in the middle get a review by nurses at home regularly and are brought back or have connection. I get a phone call or my colleagues get a phone call about the status of these individuals, and we provide real-time advice what to do to prevent hospitalizations. So that connection is important between primary care and secondary care physicians. Lastly, but not least, palliative care for these individuals are very, very important. As you can see, 70% of those who are over 80, the deaths are predominantly in elderly. A lot of these individuals will not be suitable for mechanical ventilation or non-invasive ventilation even. To start palliative intent when the disease severity gets worse is of paramount importance to give them a good death. Our palliative care teams have worked with us very closely to provide this aspect of care. We cohorted these individuals in a ward, and this sort of holistic care was provided. I put the iPad there because we were not allowing visitors to come in because it's a risk to the visitors themselves. So we were providing FaceTime to the family so that they know they can say their goodbyes. We as healthcare professionals were there with them till the end with these individuals. But this is something to keep in mind for those who may not unfortunately make it. So in summary, it's a complex disease with multi-system involvement. The symptomatology is variable. There are some high-risk symptoms, high-risk patients. If we identify them early, we can provide better care. Triaging early in the disease process is the key to provide good outcomes. Non-invasive ventilation is better to be given early, and post-discharge care is vital. So, as far as we are concerned, it's been an exhaustive experience. We've learned every week. We think we're now ready for the second surge, if at all that happens. But it's been a really collaborative effort. There's a lot of innovation that has gone on, and we feel that we have tried to do the best of what we can for our patients. And I hope we are able to share this to the colleagues who are in the webinar today to learn from our experience and provide good care to our patients. Lastly, it's been a very collaborative and very satisfying effort from our end because we have started seeing very, very good patient outcomes, and not just for the patients, but the overall holistic care we are able to provide to our patients, the families, has been excellent so far. So this is our team, and this is one of our consultant colleagues who unfortunately was admitted. He made a good recovery, and it brings up the team. It really gives us a really good high when we're able to send our colleagues home. I thank all of my team members who have worked tirelessly over this COVID period for us to succeed. Thank you for your attention.
Ashish, thank you very much. It's a really nice presentation and most informative. And I think I have got more questions than our audience. Let us see, are there any questions from the participants? Shall we take question and answers now?
Sure.
Yeah, Bharti, from your side? I think I have more questions than our audience.
That's okay.
You can start, Doctor, and then others will join as you.
Yeah, yeah. Here the whatever you given us in your lecture, okay, very informative. But here in India, I think we have a separate government hospital treating all the COVID patients now, as of now.
Mm-hmm.
They've divided actually the cases into mild, moderate, and severe.
Okay.
Mild, we mean only the upper respiratory symptoms, not much of lower respiratory symptoms, just like ILI, what you call influenza-like symptoms with fever, myalgia, not much of other respiratory symptoms. These people usually managed in COVID care centers. This is what we call quarantine homes. Now, I think the latest guideline is these people can be managed at home with all the required whatever for quarantine things. But earlier, they used to put them in the hospital actually, or in the wherever there's facilities available for the quarantine. Say, for example, the schools and colleges where they are not conducting any classes now, they used to put there, and for 14 days. Okay. Now the
Yeah.
moderate to severe cases, I know I've gone through all your presentations. Now, just let me start from one by one now. So what is your take on SCQS, hydroxychloroquine? Our ICMR guideline and Ministry of Health and Family Welfare still they suggest us use this actually, particularly in mild cases. What I have told you now, if they have other comorbidities like your say the bronchiectasis, say cardiac failure, chronic renal failure, either renal, cardiac, whatever, they still suggest using SCQS. What's your take on this?
So we are not recommending hydroxychloroquine. We've from the recovery trial, we've seen no benefit of hydroxychloroquine either in mild cases or in cases who have got established COVID symptoms, and therefore we are not recommending it at any point during the treatment or any phase of the illness.
Okay. The 3 days back, we got the revised guidelines from the ICMR and Ministry of Health and Family Welfare. They do recommend this. And of course, the severe cases, we are not using it in the recommendation. Okay. In the Kerala group, there's one, you must have heard of Calicut Medical College. There is a COVID team. What they're following, what you call LAMP regime, LAMP and PALM regime. For initial moderate cases, say this is present with say chest X infiltrates, evidence of pneumonia, mild respiratory distress. They're maintaining SACH with just 2 to 3 liters of oxygen. What they do initially, they follow PALM. P stands for prone, actually awake prone. A stands for activity limitation. They have observed sudden death actually. These people, the perceived hypoxia is very minimal because they have less of the symptoms it seems. So they have got activity limitations. The moment they say SACH is less than 94% and little exertion, and then they use low molecular weight for every patient because the COVID coagulopathy, even the irrespective of D-dimer, they start using low molecular weight even for ambulant patients there, and they use methylprednisolone even for moderate cases. 1 to 2 milligram per kg body weight. They start early because the last 2 months they are following this. This has reduced the mortality very drastically, it seems. And the people going onto the ventilator has come down drastically in Tamil Nadu. That is Calicut COVID team that has suggested. Then they used to follow earlier LAMP regime. Again, L stands for, again, see the azithromycin they are using there. L for low molecular weight heparin, A for azithromycin, M for methylprednisolone, P for again awake proning. So azithromycin, again the switch now and then they will be using azithromycin also. What's your take on this?
So
I'm talking about moderate cases when they're ambulant.
So our treatment protocols are all based on the clinical evidence. Unfortunately, there is no clinical evidence for routine use of methylprednisolone. From the recovery trial, 11,500 patients that we had recruited, there is some signal that steroids are useful, dexamethasone, especially if patients are on oxygen. It reduces mortality by 20%, and those who go on severe disease, the mortality reduction is 30%. So I can see some merit in using the methylprednisolone, although the evidence actually is only for dexamethasone.
Yeah, there's Oxford trial. They use dexamethasone, but these people have started using methylprednisolone 2 months earlier prior to that actually.
Yeah.
Actually, before that this thing was published. That's what I heard actually the day before yesterday.
Sure.
Actually,
so there is go on. There is some immune modulation that happens by use of steroids. And I think we can only advocate based on clinical trials. Our practice is very much dexamethasone 6 milligram. We can't advocate methylpred, but I can see why there could be benefit. I can't advocate it because there's no trials to support it, but I can see the rationale. As far as proning is concerned, as I said, awake proning is helpful. It reduces the peripheral strain, stress on the shear forces on the lung, and it improves oxygenation. It in itself is not a treatment, but it improves oxygenation.
Yeah, but these people, what they claim for methylprednisolone is they are telling it is short acting, fast acting, and then it's basically acts on the lung, the receptor, they're more. That's what they're claiming. Though, of course, maybe the efficacy wise may not be any difference at all, but that's what they're claiming, this group.
Sure, but we are discussing clinically evidenced parameters. Unfortunately, methylpred, logically it makes sense, but we can't advocate or use it rampantly just because there is no clinical trials suggestive. So it might be something, if the Indian group wants to publish, then it could be accepted more in the scientific community. But I think they're just using logic rather than any clinical trials, to be honest.
Yeah. Then one more thing. What should take an high flow nasal cannula oxygen?
Right. We don't use high flow nasal cannula simply because of aerosol generation. The PEEP which is provided by high flow nasal cannula is 2 to 3 centimeters of water. It doesn't readjust with the respiratory rate. So, and therefore, if you need to provide oxygenation in somebody who is severely affected, I would advocate the use of CPAP because it auto-sets, it provides you the pressure, and it provides, you can entrain oxygen with it. And so I think that is, we would recommend CPAP over a high flow nasal oxygen.
The same concern is explained in our group. People are hesitant to use CPAP or NIV because they are worried that that is also going to generate a lot of aerosol. So they are worried to use NIV. They are planning, they are trying that better to go for early intubation and ventilation. What's your take on that? Even they are worried about NIV also because of this. Whatever you mentioned about aerosol.
The company that has provided CPAP, which is ResMed, there is something called non-ventilated masks.
Yeah,
so the masks
filter for expiratory port or something, whatever.
Yeah, there is an expiratory port, but the mask itself is not, it's a non-vented mask.
Yeah.
And then if you put an expiratory port non-vented mask and have a full FFP3 protection with a hazmat suit, I think you're pretty safe. Getting over, we've managed over 100 patients with this in our unit. None of the healthcare staff were affected. So it is pretty safe, provided you have the right gear.
Okay. Then one more question is regarding the severe, pneumonia with ERDS, patient on ventilator deteriorating, and then what about your off-label therapy like remdesivir? You have been using it actually, and the plasma therapy. One of our minister from Delhi, present government is on ventilator and he has been undergoing convalescent plasma therapy.
Right.
Now the latest news actually. But since yesterday, he had been put on ventilator and he has been undergoing convalescent plasma therapy, I believe. I don't know. So just want some clarification on that. And remdesivir is available even now in India now. One company is marketing it actually. Then anti-IL-6, I don't know whether we are using it here. And people are telling that they are planning to try that also, tocilizumab. And this is off-label therapy. What's your take on that for Indians? I mean, for our setup actually.
So tocilizumab,
where the cost constraint is there.
Of course. So tocilizumab has now started coming out with good evidence in reduction in mortality up to 60%. We are using it regularly in patients with cytokine storm, those who end up on ventilator. It is best to use these therapies early on as well, because the most benefit is before the cytokine storm kicks in. But as soon as, if somebody deteriorates very quickly and ends up on invasive ventilation, then you may want to consider tocilizumab, 1 or 2 doses with remdesivir and steroids. Convalescent plasma, it hasn't shown a lot of benefit, but there is no reports of harm. In theory, it boosts your B cell or adaptive system, so it shouldn't do any harm, and it can be used as an add-on treatment in everyone. So we are offering it to everyone who's getting admitted to hospital now in the UK.
Do you measure IL-6 level before you suggesting surgery? Just other parameters will depend on?
So IL-6
Yes,
level doesn't offer any more information than what you can get from CRP, D-dimer, ferritin.
D-dimer, okay. Okay.
Yeah, those are much cheaper and much very reliable. So IL-6 levels routinely measuring does not offer you any more added information.
Okay. So there is a general talk going around here. Our community is thinking that the mortality in India is very much less compared to USA and UK and other countries like Italy. Do you have any explanation for that, or just we are not documenting things, or people are not reaching hospital, dying in periphery?
I think the healthcare system in India is very different from that of UK. UK, everybody can access healthcare system. It is free at the point of contact. So anybody who's ill will be admitted, will be given intensive care ventilation or everything from remdesivir to tocilizumab free of charge. But it is a very different healthcare system in India. Unfortunately, a lot of people are not able to afford this or go to government hospital where there are limitations in what can be offered. So I don't think it is a realistic picture of what's actually happening in India, because the access to healthcare is not universal in India. So I'm surprised about the deaths. Actually,
low mortality.
I think there's a lot of
around 3%. That's all.
Not even 3%, less than that.
Less than
overall in outside 3%, not even 1%. They're predicting now. Less than 2% it is here. Okay. Have you seen any patient dying suddenly?
Yes, we have seen. We have seen 3 patients who presented to A&E, were very fit and well, less than 60 years of age, and they died rather suddenly, and postmortem showed myocarditis.
Yeah, maybe it's arrhythmias. Okay.
So they had a very high troponin levels on presentation.
Okay.
And that's the cause.
Yeah, it's not because of respiratory failure suddenly worsening and hypoxia.
No, it's because of myocarditis.
Arrhythmias. Okay, that's it. Right. Any more things to be discussed, Dr. Bharti, from your side?
I think there were questions on the chat box, and Professor Nirmal Kumar has already answered.
Actually, okay.
Yeah, he has answered on the chat box only. Now regarding surgeries, Professor Nirmal, how you are managing in your, like, what protocols you had for surgeries of ENT?
Yes, we have, along with the other surgical associations, we have devised protocols. We have divided patients into categories. 1, emergency, life-threatening. 2, cancer, needs to be done within few weeks. 3, can be done up to 3 months. And 4, category, completely routine, tonsillectomy, etc. So we are not doing category 4, but we are doing category 1, urgent emergency, all throughout. The cancer patients have also had their operations. The category 3 we are now starting. We are calling this time-sensitive operations, such as cholesteatoma, or in the nose, if the nose is completely blocked in the chest and the airway. Dr. Ashish and I have a patient who's a charge nurse on our ward. His nose is fully stuffed with polyps. He's having asthma, which is quite difficult to control. So he is the 3rd category that I hope to do next week. So we are doing a phased return, and those patients who we are operating, we are doing testing for before the operation. We are doing self-isolation for 2 weeks, and after the operation, again, self-isolation for 1 week at least, and up to 2 weeks depending on the procedure. So this is the protocol. The consenting is very important for these patients. There is a higher risk of morbidity, either from contracting COVID during their stay in hospital, or even because of the operation, and we need to consent them, and patients have to understand the risks before they come for operation.
And do you use this povidone mouthwash or nasal before surgery, like 2 days, 3 days?
No, we, like Dr. Ashish was saying in his presentation and his question answers, this evidence-based, one of my own colleagues in ENT UK suggested that in a non-peer-reviewed publication, but the risks of povidone wash is there can be damage if it is used in the wrong fashion, and we do not recommend it because the evidence is very, very poor, not good quality evidence. We do not use it.
And then
Marti, you have any more questions? There are from the chart
what
box.
PPE, like personal protections you use for theaters?
Yes, we always recommend for all our ENT procedures, definitely wearing FP3 mask and goggles or visor for any aerosol generating procedures. But for normal procedures, which are general surgery or other procedures, that is only required for time of intubation. And once the patient is in theater, they just wear a normal fluid-resistant surgical mask. If you are in any way close to the upper airway and doing procedures, FP3 mask is essential.
Okay. All your theaters are negative pressure theaters?
No. That is not very available widely. In London, we have 1 or 2 negative pressure theaters, and in America, a few. But no, it is not negative pressure theaters. Normal theater, but the air ventilation is very good in approximately 4 per, every few minutes there is a change. So even in any room where you are doing either surgery or in procedure rooms such as endoscopy rooms, we need to have reasonably good ventilation. All the information is we have put up on our ENT UK website, where it tells you about return to work documents, about what is the requirement for room ventilation, what is the requirement for protection equipment, requirement for consenting. So every single piece of information in the last 3 months, we have put up about 100 documents in a COVID section.
We all have gone through it because
very good.
made our own.
Yes, of course, adapted it. Yes.
AOI guidelines we have made.
Very good.
We went through everything and then evidence-based we did it.
Very good. Thank you. I'm glad it's been helpful.
Yeah. Jairaj?
Dr. Vimal Kumar, I have one question for you. And there are a lot of questions for Ashish from the participants. I will take it up with 2-3 important questions from there. I want to know just what is the cause for this impaired olfactory, the loss of smell or just impaired smell? Is it because of olfactory involvement or just a mucosal inflammation, or what is the reason actually?
The most likely cause is the propensity of the coronavirus to interact with the receptors in the olfactory neuronal areas, and we think the interaction with the ACE2 receptors is the biggest reason for this, and that is highly present in the olfactory mucosa. So that receptor interaction, which is thought to happen in other parts of the respiratory system also. And Ashish, I learned something about what he said that is there in the adipose tissue. I did not know that. So I must make sure I lose some weight. But the point is that these receptors are the prime target for the coronavirus.
And, there is one recent hypothesis put forward by Indian group of, I think this chemical biology lab or somebody. Like they have said that the virus from the olfactory area will directly go to the PBC center of the respiratory system in the brain. That is pre-Bolzinger complex of the brain. So that's the hypothesis put forward, and that's why they have suggested like the autopsy of the brain and then the CSF analysis to go ahead, whether it is the respiratory center depression which is attacked by the virus that causes the failure in this, along with the peripheral.
Yes, very interesting. Yes, and Dr. Ashish, very interesting point.
Ashish should, I think that is from the Indian Institute of Chemical Biology. Along with DST, they have put forward.
Very interesting.
Okay.
I learned something.
Okay, Dr. Ashish will take up this thing. Then I think we'll have a few more questions for him from the our participants. Dr. Ashish?
Yes, I'm here.
Very important. We really need to clarify this because the TB control program, now it has become, earlier it was RNTCP, Revised National Control, Control Program. Now it has become NTEP, Eradication Program. Under this, we got the latest this thing from the government saying that all SARI cases should be tested for tuberculosis by CBNAT, that is gene expert. SARI severe acute respiratory illness cases suspected of COVID also. Now the worry from our doctors' fraternity is how to collect the sputum. Induction of sputum will induce a lot of aerosol generation. They are worried actually. For every sample you have to send, you have to use PPE. Lot of wastage of money is not available for every hospital. So what is your take on that for our government actually this is? Because that is made it a mandatory now. All SARI cases, ILI cases, anybody we get to the hospital, we have to send them for TB evaluation by CBNAT, gene expert.
I think it's in context of COVID, that's a very tricky situation.
Yeah, that's right.
Because you shouldn't try and induce any sputum, especially if you're suspecting COVID, unless you have negative pressure rooms and staff are adequately protected. It becomes a healthcare professional risk if you try and do that. So it's a very tricky situation. Unfortunately, where we practice, it's a 98% white population. We have not seen any TB coexisting with. So unfortunately, I'm not in a position to tell you what our take would be on this, but we would strongly recommend against using AGP just for sputum induction.
Yeah. Some of the people, they want to clarify what you people are doing for asymptomatic COVID patients. What we are doing, just a observation, antipyretic, nothing else.
Self-isolation.
Self-isolation.
So they want to know from your side what you people are doing there. Asymptomatic COVID positive.
Yeah.
Self-isolation for 7 days recommended for asymptomatic patients if they are COVID positive also. And important, even if they have anosmia, as I said, we must recommend self-isolation.
Okay.
And do you give vitamin C?
Yes, we give vitamin C intravenously, 6 grams a day.
Yeah. There's one more vague question from the participant. They want to know about immune boosting drugs, diet, lot of things happening here on the TV channel, lot of ads coming up. They're using that, Ayurveda treatment, Ayurveda medicine, lot of things are happening here now. They want to know about that, any role for that, any immune boost drugs, foods. Our audience want to know about it.
So vitamin D and vitamin C has some evidence because they act as immunomodulators, high dose vitamin. So we are all, if you're deficient in vitamin D, you should correct your levels. You should supplement yourself with vitamin C. For the patients who are treated, we are giving 6 grams IV. But for those, for personally myself, I've started taking some vitamin C supplements along with vitamin D because there seems to be some immunomodulatory role. More than that, I can't really comment based on Ayurvedic treatment or anything else. But one thing for sure I have taken up is a lot of exercise to improve my functional ability so that if at all I'm in the best shape, if at all I get admitted. So that would be our recommendation really.
Yeah, because this disease is going to stay with us at least till the vaccine comes or whatever is there.
Yes.
I think we need to maintain our respiratory system as well as, as you said, I think these things we should carry on.
That's right.
Celebrated World Yoga Day. So you suggest to practice yoga?
Yes, absolutely.
Breathing exercises, pranayama.
For many people are committing suicide also. That's what I heard.
Absolutely.
Push that psychologically. Yoga is
yes. meditation and yoga is very, very useful because it is such a relaxation. I certainly started it a few years ago personally, and I don't have evidence for that, but I think it has made me a lot calmer. And yes, the psychological effect of COVID is quite high. We must not forget that. In the general population, not just in us doctors, we must support psychological well-being, and I'm sure doing a little bit of meditation and yoga is very useful.
Absolutely.
Last question from my side to Ashish. What's your take on azithromycin?
We are still using it as a part of clinical trial. I cannot recommend it outside of a clinical trial as a routine treatment. There is some evidence that, again, it's an immunomodulator, might affect in early disease, but really I don't see a very big role once the disease requires hospitalization. So if somebody is being turned around from A&E who has signs of a respiratory tract infection, you might want to choose azithromycin as a choice of antibiotic. But other than that, I don't think there's a huge role.
Okay, for Nirmal Kumar, this is actually for our developing countries where there's a resource constraint. And can we use this N95 mask? Is it reusable? Can we use it repeatedly?
Yes, reusable mask like N95 is very effective. 95% protection is provided by N95 mask, otherwise called FP2, and I am very confident that it provides protection in the vast majority of situations. If you have a very high viral load in intensive care unit or intubation, then you must try and use N99, that is FP3, which provide 99% protection. But most other situations, FP2 or N95 mask is fine. And reusable. I use reusable. My hospital, I must thank. I must thank my hospital to provide all of us with a reusable mask, which we can clean and use. It is very safe and effective.
Yeah. And Dr. Ashwini, yeah, as Professor Nirmal Kumar said, like we are also in our hospital, we are using half-face respirators for all surgeries with 3M goggles. And then face shield also we use. Only for the like the face shield we cannot use when we are using doing the what do you call ear surgery, microscopic surgeries. So in that case, now we have adopted that auto tent, like
Yes, yes, we also put that up quite early in our website. Yes, that is a good option.
So we are using that. And then for larynx, microlaryngeal and all, we are using that plastic tent and doing microlaryngeal. I think this is the thing which we are taking and doing it. Any other questions?
Yes, Soclar mask cleaning agent is very effective. And somebody is asking about sodium hypochlorite.
Yeah,
sodium it's very, very effective. Yeah.
1% sodium hypochlorite.
That's right.
Yeah. I think that's the end of the questions, I think.
Excellent. Thank you.
Derek, are you there?
Yes, I'm here. I mean, most of the things just went over my head. I'm not, a doctor or something, but it was a very, very informative session.
Yeah, really great lecture.
At the outset, we thank Derek, the step one,
actually,
for giving this us this
That's
opportunity.
Right. That's right. Thank you, Derek.
Derek.
You're welcome. I have to thank you as well. And I'm sure whoever has attended this, webinar has taken away a lot of learnings from the speakers today. And I'm sure this will be available online on YouTube. Prajwal will actually enable that. And please encourage your colleagues to, view this. It's very, very important. And such detailed has gone in terms of presenting this webinar. Thank you very much, Doctor and Professor Nirmal as well.
Thank you.
Derek, can I just say something before we go?
Yeah.
Number one is Derek and Prajwal, thank you for allowing this to happen. This is the first annual series where Professor Nirmal Kumar very kindly agreed to spare time along with Ashish. And this is something we are trying to do as a part of our global training and education center. So we run a global medical program for postgraduate doctors who come here for 2 to 3 years of training to get MCH or MED program. So we actually have 60 plus faculty members who will be willing to take part in this kind of program, which would have mutual benefit both to India as well as in UK here. And it's very nice to take part. Obviously, every meeting has got some technical issue. We did have some technical issue. Padmal just told me that the YouTube account is currently it's okay now. So hopefully for the future meetings, we'll have much better arrangements, and we will probably have to check again. We did that yesterday, but we probably have to do it again to make sure we can reach a wider audience. And
Thank you.
on behalf of my colleagues here, I want to thank Step One. I also want to talk Prajwal, Derek, for giving this opportunity. And thank you, Professor Jairaj and Professor Bharati, for making time to be coordinated session as well. Thank you.
Thank you,
Thank you.
Shashindra. Thank you, Nirmal. I think
Thank you.
we'll be in touch.
Of course.
Nirmal.
Very, very
Bye.
good. Nice to meet you.
Yeah.
Nice to meet you all.
very much.
Bye. Thank you.
Thank you,
Bye,
Ashish. Thank you,
Ashish.
Nirmal.
Bye-bye.
Bye, Jairaj.
Bye. Bye. Bye.
See you tomorrow.
Bye.